Good morning and welcome to our fourth and final American Academy of Otolaryngology Head and Neck Surgery Foundation virtual global grand rounds for 2022. We have a very exciting lineup today. Disruption and innovation in otology and neurotology. This is always one of our favorites of the year. So we're very excited to be with you today. And I should say good morning or good evening, depending on where you are in the world. So I am Mark Zaffirio. I'm the American Academy of Otolaryngology Head and Neck Surgery Coordinator for International Affairs. And I will be introducing our panelists in the next minute or two. But first, just to welcome you all, we have now 1,300 attendees registered. I know many of you will be here live today, and then many others will be watching this in a delayed fashion. So we welcome you and welcome you to our Global Grand Round series. We have over 110 countries represented today in this amongst our participants in this webinar. First, before we introduce our panel, I did want to introduce our 2022-2023 American Academy of Otolaryngology Head and Neck Surgery President, Dr. Kathleen Yaremchuk. Dr. Yaremchuk.
Welcome to our international attendees. I am so excited to see so many of you here virtually from around the world. While it's great to see you virtually, it would be wonderful to be able to meet and greet one another. I hope to see you next fall in Nashville, Tennessee for the annual American Academy of Otolaryngology Head and Neck Surgery annual meeting. We have a terrific scientific program planned. We hope that you will be able to participate as well as present at that meeting. Please reach out to us if you have any ideas or suggestions for future global grand rounds.
Thanks so much, Dr. Yaremchuk, for that warm welcome to our participants. And thank you for all that you do for the American Academy. So we will go directly into our panel. So we have two very globally renowned moderators of the panel today, and I will briefly introduce them, and they will take it from here. First, we have Dr. Quinnell, who comes to us from Mass Eye and Ear, where she is the director of Mass Eye and Ear Otopathology. She is also at the Harvard Medical School, and we are very honored to have her here today with us. And then we also have Dr. Moaz Terabici, who was the 2021-2022 American Academy International Advisory Board Chair. He's also very internationally distinguished as the co-founder of the Terabici-Stamberger Ear and Sinus Institute. Many of you have probably been on his webinars before. So welcome to Dr. Quinnell and Dr. Terabici, and we will let you take it from here.
Thank you so much. I'm just going to share my screen. Okay, can you all see that? So thank you very much to the American Academy of Otolaryngology, to the International Advisory Board, to Dr. Zaffirio, as well as the team, including Katie and Elise, who helped organize all of this. Thanks to Dr. Yaremchuk as well. We are so excited today to moderate a really fantastic panel. I have the distinct honor of moderating this with Dr. Terabici, who is arguably considered the father of endoscopic ear surgery by many. I want to say just a few words about our agenda, and then we will jump into introducing our distinguished panelists. I'll say a few words of introduction about the topic, and at the end, we're going to save a few minutes at least for some discussion and questions. So our panelists include Dr. Sharon Cushing, Dr. Seiji Kakahara, and Dr. Daniel Lee. And so I want to say just a few words of introduction about Dr. Cushing. She did ask me to keep this short, but it's hard to do that. She is certainly an internationally renowned pediatric otolaryngologist. She is the director of the cochlear implant program at the Hospital for Sick Children in Toronto. I was just looking at the Newsweek rankings last night. This is the #1 pediatric hospital in the world. So a very impressive institution, clearly, and she's clearly a leader in otologic surgery there. She has delivered many, many lectures around the world on endoscopic ear surgery and innovation in otology. And we certainly look forward to her discussion today. So thank you very much, Dr. Cushing, for joining us. I'm going to turn it over to Dr. Terabici, who is going to introduce his good friend and colleague, Dr. Seiji Kakahara.
Well, as I just said, Seiji is a very, very good friend. We met like some time ago, I think about 15 years ago in Turkey, and he's been one of the main leaders and innovators in endoscopic ear surgery. And it just happened that he is hosting the 3rd World Congress on Endoscopic Ear Surgery in Kyoto, Japan, and I hope we'll get to see you all there. Alicia, I think you have your microphone off.
There. So just wanted to introduce our final speaker, Dr. Daniel Lee, who's a fantastic endoscopic ear surgeon. And I would say certainly the person who encouraged me to pursue this now 9 years ago as I started my junior faculty position at Mass Eye and Ear. Dr. Daniel Lee is the director of pediatric otology and neurotology at Massachusetts Eye and Ear. He is an associate professor in the Department of Otolaryngology, head and neck surgery at Harvard Medical School. He also has had a very distinguished national and international reputation in terms of education, in particularly endoscopic ear surgery, and bringing this to the forefront in the last 10 years. He's been the director or co-director on many US courses, including more than 16 US CME courses, as well as the first Harvard course on endoscopic ear surgery, and the co-director of the first US course on endoscopic ear surgery. So he's also just a fantastic educator, as are all of our panelists this morning. So I think you're going to really enjoy all of these lectures. So thank you very much, Dr. Lee, for joining us, and we look forward to your lecture.
Thank you, Dr. Cornell.
Thank you. So I'm just going to say a few quick words of introduction to the topic in general before we jump into Dr. Cushing's lecture. These are my disclosures. I don't think any are particularly relevant. So just taking a bird's eye view of our topic today, which is really disruption and innovation in otology and neurotology, I think there is really a huge importance on the visualization aspect of our field. A lot of what we do, of course, is microscopic surgery. We're in dark corridors and deep corridors, and better visualization, I think, really has been shown to lead to better surgical outcomes in the form of another instrument that we are all very familiar with. So in the mid to late 20th century, the advent of the operating microscope came about, and this certainly revolutionized the types of ear surgeries that could be done, reduced complications and optimized outcomes, and has obviously been widely adopted around the world. And while we continue to use that, I think today we're going to focus more on some of the newer technologies that are being used to visualize the ear for otologic and lateral skull-based surgery. I would say in the 1990s, the endoscopes really came about in the sense of pioneers like Dr. Terabici, who began using endoscopes and showed us that you can do entire ear surgeries endoscopically. And by 1997, I know Dr. Terabici had published a manuscript showing totally endoscopic ear surgery for cholesteatoma. Since then, I would say there's been a second wave of endoscopic ear surgery interest, and I would say that was in the last decade, since 2010, and I'll show you some of the data behind that. But there really has been a worldwide interest, I think, in this, mainly in the form of improving our visualization. And there's been some additional innovations in terms of the types of endoscopes that can be used, in terms of the idea of freeing up your second hand. And I'm sure we'll hear a lot about that in some of the talks today. And the third category of visualization, I would say, is exoscopes. And exoscopes are extracorporeal methods for magnification and illumination that are meant to potentially replace the microscope. So would be utilized in the same surgeries that you would otherwise utilize the microscope for. And while those have also been around since the 1990s, I would say in the last several years, even, we've seen a tremendous interest in the potential for exoscopes. And I'm showing you a few of the possible exoscopes that are available today. And some of these we've trialed at our institution. And we look forward to hearing Dr. Lee's thoughts and experience with exoscopes as our final talk today. So I just wanted to show this. This is a PubMed search. You probably are all familiar with this, which really shows this distinct inflection point around 2010 when endoscopic ear surgery really started to take off, I think, in terms of worldwide interest, as reflected by the number of publications and articles that you see. This is also paralleled by what Dr. Terabishi mentioned, which is an increase in the number of educational conferences internationally. And so you see along the bottom some of these very incredible international conferences that are focused on endoscopic ear surgery, beginning in 2015 with the first World Congress on Endoscopic Ear Surgery, which was hosted by Dr. Terabishi and Dr. Prizzuti. Just highlight the Third World Congress because we have the chair and co-chair, Dr. Daniel Lee, also on our call here. And as you heard already, Dr. Seiji Kakahata will be hosting in just one short month the fourth World Congress in Kyoto. So we all look forward to joining him there. So we really have an incredibly distinguished panel to speak to you longitudinally about their experience with endoscopic ear surgery. I thought it would be good to just take one look at the adoption of endoscopic ear surgery. This is also an article from Dr. Terabishi, which actually looks at the experience by surveying members of the American Academy of Otolaryngology Head and Neck Surgery. And there have been a number of papers looking worldwide at adoption of endoscopic ear surgery. Interestingly, it does vary quite a bit across the world. But this is an interesting graph showing the difference between surgeons when surveyed in 2010 versus surveyed in 2018. And what you can see is a significant increase in the number of surgeons who have at least tried an endoscope in the ear, and the number of surgeons who are doing endoscopic assisted or totally endoscopic ear surgery. And at the bottom, just for your reference, there is a very helpful classification scheme put forth by my colleagues, Drs. Michael Cohen, Dr. Dan Lee, and others, which is helpful in terms of organizing your thoughts about how much of the surgery you're doing with the endoscope. And so I just wanted to share one word about why I chose to integrate the endoscope into my practice. I think what you'll probably hear multiple times today is that the visualization really is absolutely incredible. So the idea of being able to look in a wide angle lens and look around corners is certainly very important for ear surgery. What we're showing here on the left is a microscopic view of the same ear that's shown here on the right image with the 0-degree endoscope. And what you can clearly see, I'll just pause it there, is that the retrotympanic view in terms of what is the true pathology with this congenital conductive hearing loss case is much more readily apparent with the endoscopic view, where you can see much further posteriorly. In this image, you can see that there's an incus, it's disconnected from the stapes. And in this image on the endoscope, you can see that the real issue here is that the posterior crus is foreshortened, that capitulum is posteriorly located, and there's clearly no connection there. So I think these kinds of images are very motivating, and I think that's probably what you'll see today through some of our speakers in terms of thinking about potentially introducing the endoscope in your practice. I wanted to just say one word about redefining anatomy. This is a common theme that we've heard with endoscopic ear surgery, and really being able to see better in the middle ear has led to, I think, a redefining of middle ear anatomy and a better understanding of pathophysiology, especially in chronic ear disease and ventilation pathways. There are, of course, 5 separate middle ear spaces, the mesotympanum being the center, and then the retro, the hypo, the protympanum, and the epitympanum. And I would argue that all of those spaces can be perhaps more readily seen with the endoscope. And I'll just conclude the short introduction with a little bit of anatomy, looking at a 0-degree endoscope image. So this is actually the same case, but this is the initial look into an ear of a patient with otosclerosis, actually. So here you see the chorda tympani nerve, the incus, the stapes, the stapedial tendon, the pyramidal process, the cochlea, of course, and the cochlear promontory. And here you can get a very good look at the cochleaform process with the tensor tympani tendon and even the otosclerotic plaque anterior to the oval window. In this image, just angling the endoscope very slightly, which is quite easy to do. You can get a more direct view of the round window. You see this beautiful view of Jacobson's nerve coursing over the promontory. You can see very clearly into the sinus tympani, which is a structure that is, or a space that is considered somewhat elusive with the microscope. And here you can see the pyramidal eminence. The ponticulus is under this area, the subiculum here, the fustus here, the funiculus, and you can see the area of the subcochlear tunnel. So there's a whole ventilation system here heading toward the petrous apex. And so in these views, I just wanted to show you a few case examples of how you can see the mesotympanum, the retrotympanum. Here are the labeled structures. And as we mentioned, you can also see the protympanum. So this is a great case where we were using the endoscope in a different way. This is a case from my practice in which there was a patient with a cerebral spinal fluid leak and an elderly patient. And so we were obliterating the ear with a tympanomastoid obliteration and looking down the with the endoscope, even through the mastoid cavity, you can actually see into the eustachian tube quite well. And here you can perceive that there is a dehiscent carotid artery. So very helpful for understanding how to pack and occlude that eustachian tube. And the last short video, or the second to last one here, is the idea of looking into the epitympanum, which I think we'll see a little bit more today with the videos, and just showing you here that you can see certainly the lateral semicircular canal, and remove disease in the epitympanum with the endoscope. And finally, just a quick view at the hypotympanum with another case that was looking infracochlearly to drain a cholesterol granuloma that was in the petrous apex. And here we are doing some drilling just below the cochlea. So we're looking here at a left ear. This is the cochlea here. The round window is posterior here. And this is drilling that's happening between the carotid artery anteriorly, the jugular bulb posteriorly, and the endoscope really affords this incredible view into the hypotympanum as well. This is a look actually into the petrous apex through that infracochlear tunnel, and you can see some of the cholesterol granuloma in there. And here we are irrigating out the petrous apex through that drilled opening, and then placing a small drainage tube. And so the endoscope really provides an excellent view of many of these different areas into the middle ear. So with that, I'd like to turn it over to Dr. Cushing, who will be our first distinguished panelist.
Excellent. Thanks, Alicia. It's really a joy and a treat to be here with you on a Saturday morning. This is probably the best thing I'm going to do all day on call. And so, you know, where I'll start is that, you know, I'm really humbled to be here. I'm not a pioneer in this, and, you know, I'm surrounded by excellence. And I hope that sort of my presence here provides an approachability and the knowledge that if this is something that you're thinking about adding to your career that you weren't trained in, you actually can do it. So that's going to be the first part of my message. Now, I have a few disclosures, and probably the biggest one is that I work with a pioneer. So Adrian James is one of my partners. His office is next to mine, and his role in endoscopic surgery has been important, and his role in my career has also been important. And I'm going to sort of navigate how that has allowed us to adopt things in children and how we're considering using this technology to push the boundaries, because today's really about that. It's about pushing the technical and the boundaries, but also pushing what we do, in whom we do it, and when we do it. And so that's what we're going to think about in pediatrics. Now, endoscopes have changed us as surgeons, right? And so they've not only changed what we do, but they've changed us as surgeons, and they've brought something to pediatric patients, both in terms of challenges and in terms of benefits. And you know, certainly the adoption of endoscopic practice was first applied to adults, as is sort of most innovations. We start with adults and then we move to kids. But sometimes what we find is that the benefits and the advantages in children are actually supersede what we can achieve in adults. And I'll focus on that. And then we'll finish off with a little bit of like what's coming next, because there's exciting stuff around the corner that you're going to hear about today. And I'll share with you what I think is coming around the corner. So these procedures have changed how we operate. And so this is Adrian's learning curve. And I was a resident when with Adrian initially. And so, looking at this, what we can see is that, again, he had probably what is pretty typical, of a learning curve. And, he's gone so far as to sort of get into his psyche and see that sort of this early stage with slow progress was probably secondary to some uncertainty, some difficulty. He didn't have a pioneer in the operating room beside him. This middle purple part is really about adding, once you get your feet wet, sort of adding some tools to your technique that then sort of make things easier. And the last bit of it is sort of digging your heels in and having conviction that, yes, I can do this and it's appropriate for me to do that. In comparison, this is my learning curve. Which looks very different. And it took me a long time. I was 8 years into my practice before I did a completely endoscopic tympanoplasty, but then I never looked back. And when we think about why are our learning curves different, we can think about the things that get in the way of us adopting new techniques. For me, it was about creating room in my learning curve. When I was first on staff, again, you realize when you're on staff that you didn't learn everything in fellowship and that you're still hanging off that learning curve when you first sit down in the chair as a staff. And so for me, I needed to get comfortable with that. It might have been different. Adrian broke his leg like 2 weeks after I started, and so was actually out of practice for 4 months. And I wonder if my initial start might have been different. If he'd been around, but that just was the case. You need to have a margin to slow down. So you're going to get slower when you start to add these things in. And so again, you have to build that in. And so you have to be fast at other stuff so you can slow down when you need to. For me, confidence, and again, that might be, something that I can share as a female surgeon. Again, I probably had ability beyond confidence, and that's probably why that learning curve, I clearly was ready, but maybe I didn't believe I was. And so perhaps that's why my learning curve looks that way. The other thing that was critical was cross-pollination. And so this is where, as a staff surgeon, you really have to set your ego aside, because residents would work with Adrian and they would come in and they actually knew more about how to do this than I did. And I remember that first one, 8 years in, I said to the resident, okay, you're taking me through this case. Tell me what Adrian does. Okay, you be the Adrian. And I think, again, that requires a special approach. So this part of the talk is really just garnered about saying that this is something you can do. How we get there is different between all of us, but I am really glad that I took the plunge and haven't looked back. So let's talk a little bit about that purple spot. So the how, because there's lots of things that can make life easier. One of them is having the right size endoscopes and the right equipment. You don't have to have that to start, but certainly it helps you get up that learning curve. For us, we love our suction dissectors. We work in an envelope funded system. There's not a ton of resource. And so we're very careful about what we add. But here you can see sort of a video of what it looks with a suction dissector and without. And so that's really been the key. And we have a few specific instruments that we think are worth having. The other thing in pediatrics is sort of the ability to use non-autogenous grafts, and in particular with tympanoplasty, not to have to rely on tragal cartilage where the size can be variable and be able to do things fully incisionless. As a little note, we actually use the sinonasal graft because we like how it maneuvers better. So I always like to say that, because we really do pretty much exclusively use non-autologous grafts for tympanoplasty. And then the curved drill bit, again, this isn't a must have, but really can make it easier in terms of those canals that are a bit difficult. Certainly if we extend into cholesteatoma surgery, this is a must have, but it can really make a difference in having these sort of guarded curved burrs. So that's sort of the technical aspect of how to make things easier. Now, what about kids? What are the limits? Like I said, there's some advantages and disadvantages. And so the ear canal is narrower in children, and that can be a function of age. It can also be a function of syndromic status, like our kids with trisomy 21 and other diagnoses. But the younger you are, the shorter it is. So it's a whole lot closer and a whole lot more straight on. And so I think that, again, limits that we perhaps thought about earlier on, we're now seeing them melt away as we have indications going into younger children. And so I think that really there isn't a specific age limit. It does depend on the case. And it's also something, this is one of the boundaries that I think is going to continue to be pushed for lots of different reasons. Now the ear canal grows, children are moving targets. And so again, things do get larger over time. They also get more curvy over time. So there's advantages and disadvantages. But the tympanic membrane height doesn't actually change over time. When we look at the feasibility, so again, in blue, we have post-oral approaches, and in red, we have endoscopic approaches. Again, even children, as young as 3 years of age presenting with congenital cholesteatomas can be very appropriate candidates. So again, we shouldn't let age be a point blank limit for us. People often worry about the size of the tragal cartilage. And again, you can see that the growth is exponential in the early years of life and then continues out to the teenage years. So again, sometimes it is hard enough to get sufficient quantity, especially for big defects or cholesteatoma cases. But that's again where some of the non-autologous grafts can come into play. Now, let's talk about how we do things and why we do things. And so again, there's a lot of literature and sort of even how we teach our residents about when do you do tympanoplasty. And a lot of us, wait, we wait for maturation of the physiology. And again, there's some good data, such as this meta-analysis, to say that that is helpful. The younger you go, the more failures there are. There's some more recent data that suggests that perhaps age is not as significant. And I think that, again, how we consider age and timing of tympanoplasty depends on the burden of the disease. And I think that's where the endoscope is disrupting what we previously think about timing. Let's think about the really, really little kids. So this is an 11-month-old with the first branchial. And again, you can see that we get a very nice view, even with a 3mm endoscope. The tympanic membrane is closer in this age group. It's a little harder to stabilize the instruments just because there's less of an ear canal. It's sort of like when you have opened the mastoid and you're using your endoscope, you've got less leverage. And you just have to be extra careful with your incision placement. But I think it is doable. And I would expect that the pioneers on this panel would echo that sentiment. And I'll tell you a little bit later why it's important. So we can do it. And it seems to be, it's safe, but doesn't make a difference. So is it any better? Is it any worse? Well, certainly when it comes to outcomes, it seems to at least be equivalent. So when we looked at our series of patients with totally endoscopic tympanoplasty versus a traditional post-auricular approach, which was our workhorse, there was no significant difference with success rates being in the high 80s on both sides. So it's at least equivalent from that perspective. In terms of hearing outcomes. And again, there's a few moving parts here because when we went to totally endoscopic, we also went to biodesign grafts as well. So again, what we see is that there's equivalent hearing outcomes in these kids with tympanoplasty. So far, no reason not to consider it. If we dip into cholesteatoma, again, for middle ear cholesteatomas, we were found that we had less residual endoscopic disease. And certainly that is, you can see that clearly when you see those beautiful videos that Alicia shared in terms of the visualization. It is so much easier to deal with middle ear cholesteatoma with an endoscope from a visualization perspective. So that is in keeping with it. Now, what do patients think? So, what matters to patients and families is pain. And what we saw was a reduction in both the duration and the severity of discomfort following endoscopic surgery. Our length of stay went right down. And we're sometimes a little bit of a slow adopter up here at SickKids. So we used to keep our tympanoplasties or anybody with a post-auricular approach overnight, which is probably a little bit behind the times. But now length of stay is about an hour post-surgery. We were faster with surgery, so about 20 minutes quicker. And I should have also added here, I think we're better teachers. I am so much more comfortable, teaching some of our residents and fellows because I can see what they're doing. There's not this sort of assumption that you see what I'm looking at? Yeah. I can get up. I can point to the screen. We can, everybody's into it when we're doing this, the anesthesiologists, the nurses, and it's just such a better teaching tool. Kids can go back to sport a little sooner. Again, you're less worried about them getting a hit on the head. And so I think return to sport and activity is significantly improved. And complications are reduced. So these are uncommon things that happen from post-auricular incisions, but they happen. This child with the keloid, that's a tympanoplasty incision, right? And so we completely avoid that whole domain. And the final bit is patient and parent satisfaction. And, what I can tell you is that one of the things I did when I first started doing these, just to sort of buffer my confidence, is I didn't tell families that I wasn't going to go post-auricularly. And when I came out, nobody was unhappy with me when I said I didn't have to make an incision. In fact, they were overjoyed. And so patients and parents are, certainly satisfied when it comes to a totally endoscopic approach. So I think, where we're at is that TEAS is feasible. I would say that it is likely feasible at almost any age and in almost any children. There's going to be exceptions to that, but I really do think they're few and far between. I think, again, equipment is helpful, but not essential, especially when you're starting out. And really, again, we're going to see sort of some extensions of the techniques in Seiji's and Dan's talk in terms of where we're going. I think that our outcomes are equivalent, at least, if not better. And we have this reduction in morbidity that is parallel to patient and parent satisfaction. When we think of the challenges, I think, many of them are personal in terms of us, getting up a learning curve and learning to do something when at times we don't consider ourselves learners anymore. Again, access to equipment can be helpful, and that may be a challenge in some of the places that we have present today. But I think what you need is actually very little and very focused. And I think that that's surmountable. So we're going to just think to the future now in this final slide in terms of, what's next. And so I think that, in looking at what is feasible and what the outcomes are, perhaps, again, we've already begun to reconsider the age and intervention. And I think tympanoplasty is a very good example of that. And the thing about kids is it matters what we do and it matters what we don't do into their development. So who that child becomes, we have an impact on that. And that's a pretty hefty responsibility. And if any of you have ever been the parent to a reluctant swimmer, you can appreciate the developmental impact of children not learning to swim. And so, again, I think that that is something that is hugely important that we probably haven't considered when we counsel around tympanoplasty. And perhaps doing it earlier, even if there is a slightly larger risk of failure, is less significant when we do it endoscopically, because the burden of failure is probably less than if I'd opened that ear. And so again, maybe we have to shift our thinking about what's the appropriate balance between risk of failure and developmental impact, particularly on important activities like swimming. Now, the second one is a really sort of look to the future thought. And so gene therapies have come. There's 2 trials that have been FDA approved since the American Academy meeting in September. And that's a really exciting time for us, for those who look at kids with hearing loss. And I have no doubt that an endoscopic middle ear approach is ultimately how we're going to deliver these therapies. It's not how we're necessarily going to start in all cases, but there's no doubt in my mind that that's going to be the least morbid route. The other thing that I know is that children are going to be the targets, and not just little children, infants, children and babies under 6 months of age. And so I think that if ever there was a time to get that endoscope into your hand, it's now, because I think that this is really going to expand as we position ourselves to be capable of delivering these therapies to our kids. So I will stop there. I think I finished a little early. I was excited and talked quickly, but I'll hand it back over to Alicia.
Thank you so much, Dr. Cushing. What a fantastic talk. You always have so many astute observations, and thank you for that. So next will be Dr. Seiji Kakahara. And Seiji, if you want to just share your screen.
Okay.
Thank you so much for joining us.
Thank you, Alicia, for having me here. So let me share my video. Can you see my video? Thank you very much, Alicia. Vatso, for your kind introduction. First of all, I'd like to express my appreciation to AAOHNS for inviting me to the very exciting Global Grand Round event. My talk today will focus on new technology in ear surgery. I have nothing to declare. Before talking about teeth, I'd like to take a short detour and talk about what ear surgeons have sought as their goal for ear surgery. Simply put, the surgical goals for ear surgery have been to remove diseased tissue, make a dry safe ear, preserve normal anatomy, and improve hearing. However, if you go beyond the simple, straightforward goals, our ultimate goals of ear surgery are aimed higher at the less invasive, safe, and functional surgical procedures, which result in a predictable outcome. What really opened the door to the widespread adoption of teeth was the introduction of Full HD camera system, which was a huge breakthrough. The 4K camera system has allowed us to go even further with its advances in optical imaging. I'd like to show you a video of STP surgery. We perform teeth. We can see the entire tympanic cavity all at once after elevating the tympanometal flap. However, we need to remove the ESC bone to achieve precise manipulation. We perform Fish's reverse procedure. Now locate the piston of all Teflon in the place. I cut IS joint, stabilizer tendon, posterior crus, and fractures the anterior crus. You can see the piston located in the ideal position. So today, a safe surgery with a predictable outcome can now be achieved via teeth with the advantages of less invasive procedure. While the endoscope changes the viewpoint of the surgeon, it facilitates good visualization and sure and steady manipulation that surpasses what had been achievable prior to teeth. Another defining feature of teeth is that it's a heads-up surgical procedure with the same HD surgical image visible to not only the surgeon, but also everyone present in the OR. On the horizon is the exoscope, which can replace the microscope and enable complete heads-up surgery in combination with teeth. What we are aiming in teeth is functional surgery. The three goals set forth to achieve a functional surgery are restoration of ventilation, mastoid preservation, and visualization and manipulation of hidden areas. This enables mastoid preservation. The strategy we chose is retrograde mastoidectomy on demand, endoscopic inside-out technique. We perform transcanal atticotomy and atticoantrotomy depending on the extension of cholesteatoma to preserve mastoid bone and mucosa as much as possible. We are able to successfully perform this by using powered instrument, which requires considerably less bone removal than microscopic approach. This has several advantages, as you can see here. In addition, this is a head-up surgery. The strategy we chose for the middle ear cholesteatoma is personalized medicine. We have developed MRI plus CT image to get precise location of cholesteatoma before surgery. This pre-surgical information is a key to personalized medicine in ear surgery. Here you can see is a patient with a cholesteatoma located in the tympanic sinus. This slide shows our strategy to treat cholesteatoma. Here you can see the division of middle ear space using the PTAM staging system proposed by Japan Otological Society. In the era of with corona, when cholesteatoma are limited to the P, T, and A, we only use a chisel, hammer, and curettes and non-powered teeth because safety already appeared to be built into non-powered teeth. We will see this topic later. We also treat all cholesteatomas extending up to and including the antrum before the Drazon line with powered teeth as long as the cholesteatoma is not infiltrated. We treat those cholesteatomas which extend into the central mastoid beyond the Donaldson line with a dual teeth and MES or exoscope approach. We perform non-powered teeth for artichotomy with chisel, hammer, and curette. We perform powered teeth starting retrograde mastoidectomy with ultrasonic aspirator and high-speed curved bar, leaving a thin bony plate. Then the bony plate is removed with chisel and hammer. Here you can see the representative case of underwater powered teeth. This is a case of pars flaccida cholesteatoma. I first start artichotomy with a chisel and then remove IS joint. Then I perform underwater teeth with high-speed curved bar. In addition, all teeth procedures have the added advantage of working within the closed surgical field. This closed surgical field is much more important in this age of COVID-19. We perform a dual approach in the case of extensive cases. A double meaning in that dual referred to two types of surgical procedures which are performed in the same surgery, teeth and EXES or MES. Two port, a transcanal port and transmastoid port. This slide shows you our strategy for cholesteatoma. We choose non-powered teeth, powered teeth, or dual approach, depending on the pre-surgical evaluation of the cholesteatoma extension. Pre-surgical evaluation of cholesteatoma is made by CT and MRI. Here is a case of 5-year-old girl with a congenital cholesteatoma. CT shows diffuse shadow in the middle ear. However, MRI revealed that cholesteatoma was located in the attic and tympanum. Therefore, we decided to perform a non-powered teeth. In the lower column, this is a case of a 12-year-old boy with pars flaccida cholesteatoma. In this case, CT also shows a diffuse shadow in the middle ear. However, MRI revealed extension of cholesteatoma beyond the posterior course of lateral semicircular canal in this case. So we perform the dual approach. So as with all new technologies and procedures, we still have much room for improvement or as we say in what has now become the international language of business management, Kaizen. Here, I'd like to introduce some of our other research activities and such improvement and advancement. As you can see here, IAMS, Intelligent Arm Support System, follows the movement of surgeon's hand. It stops and can support your hand when you want it to. We evaluated the handshake from the operation video. You can see much less shake with IARMS. We are now using the second generation of IARMS. To overcome the difficulties associated with the one-handed surgery of teeth, we developed forceps with non-slip surface treatment technologies, including straight, right-curved, and left-curved forceps. This technology makes it possible to suspend a filled 1.5-liter bottle with these forceps. In this video, now I'm using these forceps to remove the matrix of the cholesteatoma from the anterior curve of stapes, as you can see here. We have recently developed Zaosonic, a new ultrasonic aspirator with a local company here in Yamata. Zaosonic is an ultrasonic aspirator which has built-in irrigation and suction with several vibration modes. This video shows how you can remove the shell from a raw egg without damaging the membrane. This is possible because the Zaosonic removes hard tissue but leaves soft tissue intact. Now I'd like to show you the representative case using ultrasonic aspirator. We have two types of tips, accurate and telemesser. This is a telemesser, and this is the curate. After the switch on, you can remove bone very easily. You can also perform underwater teeth with a bright clear view. You see less bubbles in the operative view field. We found that when performing powered teeth using Zaosonic as ultrasonic aspirator, fewer microdroplets were observed during and after 30 seconds of cutting than has been reported for bone cutting produced, such as mastoidectomy. Our results demonstrate that powered teeth with Zaosonic produce fewer microdroplet, while underwater teeth, either with Zaosonic or a diamond bar, reduced microdroplet dramatically. In addition, the use of curette produced very few microdroplets as expected. Thus, powered teeth with the Zaosonic, underwater powered teeth, and non-powered teeth can all be considered safer options for otological procedure performed in the COVID-19 era. The reason for the superior result of Zaosonic can most likely be attributed to not only the suction function of the Zaosonic, but also the fact that the Zaosonic emulsifies bone rather than drilling into hard bone. If you want to learn more, we published a book on innovations in endoscopic surgery in English. Finally, I'd like to remind you that we will be holding the EES 2022 on-site in Kyoto. This Congress will be held from December 5th to 8th among the autumn leaves of Kyoto, followed by a satellite seminar in our hometown of Yamagata. I encourage you all to attend in what should be an even new and better new age, and registration is now opened. Still opened. Protecting smiles, smiles protecting the world. Thank you for your attention.
Thank you so much, Dr. Kahata. Do you have any last comments there?
Join us in Kyoto.
Terrific. Well, what a true innovator and what an incredible whirlwind of so many innovations in ear surgery. So thank you so much for that really just fantastic lecture. And our third distinguished panelist here is, of course, Dr. Daniel Lee. We are so excited to hear what you have to say about the next frontier.
Well, thank you, Alicia, Mark, the Academy, for the opportunity to participate in this exciting global grand rounds. Seiji, always a difficult act to follow. I love that egg video. That's incredible. I hope I can have one during my breakfast in Kyoto next month, and looking forward to giving it a spin. So the title of my presentation is Next Frontier, Exoscopes for Otology and Neurotology. And these are my disclosures. So I wanted to present the rationale for using exoscopes in otology and neurotology, and that is the ergonomic advantage. And so surgeons work hard, 2,500 hours per year or more on average, and 1/3 of our hours are spent in the operating room. And this has a negative impact on our musculoskeletal system. Survey studies suggest that up to 74% of responding otolaryngologists report pain or discomfort due to work, and this is a problem. In a Lancet study from 2016, the authors state that when burnout was seen as a crisis of well-being affecting physicians' personal lives and work satisfaction, well, no one really cared about that. But now there's evidence, quantitative data suggesting that burnout negatively affects physician effectiveness as well as patient safety. Healthcare organizations and the public are justified to be worried. There has been extensive studies on perioperative, intraoperative work environments in order to enhance patient safety, but this is really poorly understood from a surgeon safety standpoint. I believe this is a big problem. We need to really focus on this going forward. And so the goal of improved ergonomics is to reduce human error, increase productivity, and enhance safety and comfort for the operating surgeon. A more recent review examining ergonomics in otolaryngology was a systematic review and meta-analysis authored by Ryan and Tolosano and colleagues in Laryngoscope 2022, and they focused on work-related musculoskeletal discomfort, or WRMD. And so they looked at almost 2,200 participants who met criteria for the meta-analysis, and up to 84% underwent medical treatment for WRMD, work-related musculoskeletal discomfort. 5 to 23% took time off of work, and 1 to 6% stopped working completely associated with their work-related musculoskeletal discomfort. This, folks, is a problem. When examining objective measures of ergonomic posture during routine otolaryngological procedures, moderate to severe risk of injury was associated with routine clinic and surgical procedures. No procedures that we perform in otolaryngology were considered to be low risk in terms of quantitative objective measures of ergonomic posture. And so really conclusion here was poor ergonomics impacts productivity, longevity, and quality of life. And for otologists, it's really the stack height of modern microscopes that results in poor ergonomics. And so the modern microscope has fantastic optics and camera attachments and a teaching head, which is really great for many different reasons. But if you turn back the clock to the era of John Shea, the pioneering surgeon who developed the modern stapedectomy approach, who performed thousands and thousands and thousands of middle ear operations, he actually took full advantage of a very small, compact, and simple binocular microscope. And this reduced stack height that you can see here compared to the modern microscope is really quite different. And in fact, John Shea enjoyed better ergonomics during surgery than Dr. Nick Duger does today. And Nick Duger being an average size male surgeon, you can still reach the surgical field fairly easily with the arm suspended and supported by a surgical chair. But in the end, this still puts strain on the upper neck, back, and shoulders. In another example, this was one of our brilliant pediatric surgical fellows who's now in practice back in Israel. And you can see that the stack height really influences her ability to safely reach the target tissues. Her arms are outstretched. She's a gifted surgeon, but she's now being asked to perform a highly technical task with the arms outstretched, with the fingers barely able to reach the tips of the instruments. And this is entirely because of the stack height of the modern binocular microscope. And if we care about diversity, equity, inclusion, and if we care about the safety of our patient, as well as the ability for us to effectively train our colleagues who have very diverse morphologies, different limb lengths, for example, then we need to think about alternative approaches to be able to address this clear problem, the stack height of the modern surgical microscope. How can we improve ergonomics using the traditional microscope? And so in a survey study done by my friend Matthew Young in the UK, he looked at the effects of prolonged microscopic work on neck and back strain amongst otolaryngologists. To get to the punchline with this data set, the highest prevalence of chronic neck and back problems were seen amongst otologists, who are surgeons of the microscope. And in order to potentially overcome this problem with the microscope, he proposed this novel redesign of the operating chair called the prototype postural support chair. And so you actually sit in this chair backwards. And so the backrest becomes the rest against your upper torso. And then a custom bar is fitted to the back of it and is used to suspend the forehead. And that helps to support the upper neck and shoulders. Is this the way forward? Perhaps. I would propose clearly heads-up surgery as an alternative approach to improve ergonomics and make otology and neurotology procedures more safely performed for all of our participants in the operating room. And so heads-up surgery in our field, of course, includes endoscopes for small surgical corridors, as well as exoscopes for open surgical corridors. But don't forget that the exoscope is a replacement potentially for a microscope and can easily be used for transcanal cases, such as a stapedectomy or a transcanal tympanoplasty. And this will be the focus of my presentation this morning. And so to briefly summarize, there are three main options for surgical visualization and magnification in our field. The first clearly is the microscope. The second is the 2D, and in the future, hopefully more 3D endoscopic designs. And last, the 3D exoscope. The 3D exoscope, as you can see, has a similar focal distance as a traditional binocular microscope, anywhere from 20 to 50 centimeters, except visualization occurs not through the oculars, but rather projected on a HD or 4K monitor using 3D glasses, or in the case of a recent iteration, the use of a head-mounted display, essentially digital goggles that are worn by the operator as well as by the surgeon assistant. And so what is an exoscope or digital microscope? This is an example of robotic-assisted technology that we used to perform a suboccipital approach for resection of a vestibular schwannoma. The concept really dates back to the mid-90s in the neurosurgical literature, and this was the first paper that I could find that described the use of the exoscope, which was at this time a frame-based videographic system for intraoperative guidance of surgical resection. And essentially, this was an endoscope or video camera mounted outside the head, hence the term exoscope was coined. And this allowed one to project the surgical field onto a simple monitor, video monitor at the time. It was fairly crude, I could imagine. And on top of that live video feed, they could overlay imaging from the case in order to help to ensure accurate resection of tumor and minimal resection of normal brain parenchyma. So this was one of the first examples of the use of an exoscope in surgery. And again, this is really through the neurosurgical literature. My first experience with an exoscope was at Doug Bacchus's course in Seattle, and I was with my good friend Alex Huber from Zurich, Switzerland, and we were using really one of the first prototypes of an exoscope for skull-based surgery, and this was a robotic-assisted arm, a two-dimensional camera, and it was really an amazing experience to understand that one could appreciate an immersive 2D view of the field and perform a basic bony dissection through the mastoid cavity. In 2019, we published our first series. I think this is one of the first papers describing the use of exoscopes in otolaryngology, and we examined its utility in otology and neurotology-based cases. Exoscopes have several common features. One, they have a 3D, HD, or 4K video camera and effector, a high-intensity light source, a camera holder or arm, and that can be very simple, articulating arm or robotic-assisted type of an approach, a foot or hand controller, a 3D video panel, or in the case of a newer system, a head-mounted 3D display, 3D glasses for users. And examples of how one can configure such an exoscopic system into an operating footprint in which you have a large screen with a fairly medium-sized footprint that can be positioned in front of the operator, and smaller screens can be used for the observers. So it's a fairly immersive experience, and for the participants and the observers and learners in the room, it's a really phenomenal opportunity to teach using an exoscopic approach. We examined our experience with 11 exoscopic assisted cases that span the range of cases, including canal wall up and canal wall down mastodectomies, subtotal putrescectomies, tympanoplasty, as well as 2 suboccipital craniotomies for resection of vestibular schwannoma. And to briefly summarize our data set, we concluded that exoscopic assisted surgery in otology was associated with a lack of neck strain and fatigue compared to the microscope, as shown here. Interestingly, the image quality favored the operating microscope, but this was not found to be a significant difference between the two different technologies. And so our initial impressions: advantages: a compact camera unit, better ergonomics, like less neck strain, an immersive video experience is really fantastic for teaching purposes. Disadvantages: much like the regular microscope, inadequate lighting in narrow spaces, hence the reason why we have endoscopes now in the operating room. Image quality not quite equivalent to the microscope. We are bumping up against current technology being used, which is a 4K system. Although when you push the companies, they will tell you that in fact the 4K 3D system is 2K plus 2K fused together. So it's actually a 2K 3D image, which is why oftentimes when I was using these exoscopes, I would switch to 2D to see in 4K when I was doing some of the tumor dissection off of the facial nerve. And so I think with advancements in sensor technology going up to 4K, 8K, and 16K, we'll be able to see video image quality, which will begin to better approximate that, which we enjoy with ground glass optics. And finally, the video system can challenge small operating footprints, but I think with boom mounted monitors that get better and better and even larger, as of recent iterations that I've seen, this will probably overcome the concern about the footprint problem. And finally, for some of my colleagues, the 3D experience is not for everyone. And some people got either dizzy or they became nauseous or had headaches from the prolonged use of 3D goggles. The exoscope was quite helpful during the first height of the pandemic, in which we were very concerned about airborne aerosols and contamination of the field and a risk to personnel, as well as the inability to wear full PPE when using a microscope. In this case, we were turning a craniotomy flap to expose the posterior fossa to be able to resect an endolymphatic sac tumor. This was done entirely with a very simple, low-end, two-dimensional exoscopic system with a very simple barrier drape, and we were able to wear full PPE for all personnel involved in the case. So what about robotic-assisted exoscopes? And so these new generation robotic assisted exoscopes have a head mounted display, or HMD, as shown here, being worn by Song Cheng, our current second-year fellow. That's a good look for him. These robotic assisted systems include a merged 4K resolution of the surgical field that is positioned on a head mounted display, otherwise known as an HMD. So it projects a three-dimensional representation of the surgical field. The HMD has sensors, which allows for interpretation of head motion of the surgeon. And this connects wirelessly through a 6-axis robotic arm and camera head, the end effector, which carries out corresponding movements. One can also change the number of parameters by using just the movements of the head. You can select different working distances, which is still something that needs to be refined with this technology. There's to be an infinite range of working distances, but the company assures me that this will be improved upon. The surgical assistant can use another HMD, and then a second or third monitor can be used in the OR so that the rest of the staff can follow the operation. Our hypothesis in this preliminary study was that a robotic assisted exoscope could enable visualization of the surgical field at extreme angles without compromising ergonomics. And this was a study that was put together by Alejandro Garcia, my brilliant postdoctoral fellow. And you can see Dr. Santos here performing a middle fossa craniotomy is able to comfortably sit and look forward without any strain to his neck or back, as the end effector is swung over at an extreme angle to be able to get him the view he needs to complete the lateral skull base repair. And so our aim in the study was to evaluate the efficacy of using a robotic assisted system with HMD in ear surgery and assess the surgeon's perspective on both performance as well as ergonomics. So briefly, this is a prospective cohort study from early 2022, focusing on otology and neurotology cases. We used either a robotic assisted exoscope with the HMD system, a Hopkins rod telescope, or binocular microscope for each of these cases. And some of the outcome metrics included the NASA task load index, as well as visual analog scales. So briefly, the results, a total of 9 cases were performed using the system by 6 different surgeons. So it's a very small study, pilot study. The subjective visual analog scale surveys suggest a lower familiarity with the robotic assisted device compared to the microscope and endoscope. Not a surprising finding. What was interesting is that there was an increased mental demand with the robotic assisted device, as well as an increase in physical demand when using the microscope. And some of these data are summarized in these data plots. And so in the case of physical demand, the microscope was scored higher compared to the robotic approach or to the endoscopic assisted approach. So to conclude, the robotic assisted exoscopic surgical approaches for otology is potentially safe and feasible. The most common procedures done for otology were completed safely with the use of the robotic assisted approach with HMD. The experience was ergonomically sound with decent visualization, and one can visualize the field very similar to a traditional digital operating microscope. One common concern raised by all operators was the need to wear the HMD itself, and it's fairly large and bulky, and I suspect with improvements in technology, this will no longer become an issue over time. And finally, the increase in mental demand, we believe, might be due to the possibility of having to visualize the digital representation 3D through the HMD system, which can be taxing at times during a long procedure. And so with that, thank you.
Thank you so much, Dr. Lee. What a fantastic lecture. You continue to push the boundaries of new instruments and innovation. And I have certainly personally benefited from that tremendously at our institution, getting to try some of these devices that you've brought in for trial. So thank you for showing us the next frontier. And I think, thank you. And I think with that, we have a few minutes for some questions and answers, and I'll just share my slides again. And for any of you out there who want to put questions in the chat, please feel free to do so at this time, and we will try to answer them as we go. But I have a few questions for our panelists to start us off here. So these are some general questions. So thank you all for really just a fantastic panel, and just taking a step back, wanted to get your thoughts on how you would apply some of these technologies if you were just beginning in your practice. And so just looking at the endoscope, and this could be for potentially Dr. Cushing to take first, but if you had to think about which type of case might have the biggest potential advantage of doing a case endoscopically, what are your thoughts? I listed some potential thoughts here. On the left that you see, on the right, you see this image of a very curved ear canal in a condition called Turner syndrome, which is a genetic condition in which patients oftentimes have a very curved ear canal and chronic ear disease. And on the bottom, you see a patient ready for osteoplasty after cholesteatoma. But what are your thoughts in terms of what would be the cases that you would dive into first with endoscopes?
I guess I think about it in a couple of different ways. So there's, what can I do totally endoscopically? And to me, the tympanoplasty is the way to start from that perspective. But that's generally not the first time you use the endoscope. And I said, so, for those 8 years in my practice, where I didn't feel like I was an endoscopic surgeon, I used the endoscope, not infrequently, probably for most cholesteatoma cases. And so I think that, using it a bit here and there is a very good way to start. But I think when you feel like, okay, I'm ready from a confidence perspective to cross that threshold, a TM perf is a lovely way to actually sort of feel like you're doing it all. I wouldn't pick this one because what's difficult with the microscope can also be difficult with the endoscope, and sort of bringing out the drill and doing that endoscopically sort of took a whole other sort of layer of skill set. So again, I would pick one that's going to be a bit of a win in that regard. So that would be my, recommendation for someone who didn't learn the technique in their residency or fellowship training.
Terrific. Well, thank you for those thoughts, Dr. Cushing. Dr. Kakahara, is there a case that you feel, being a very experienced endoscopic ear surgeon, for those of you out there who may already be using the endoscope in your practice, is there a particular case that you think offers the biggest advantage to using an endoscope?
So for congenital ocular anomalies, it's very good indication for teeth, because you can see the whole cavity all at once, entire tympanic cavity all at once. So you can do it very easily with the case of congenital ocular anomalies. And also, so in the case of cholesteatomas, our data shows, more than 10 years data shows, more than 70% of cholesteatoma can be done by teeth only. So still, we need, for the 30% cases, we need microscope or exoscope to perform surgery. So.
Terrific. And Dr. Lee, any other words of advice on which cases to address endoscopically? I think you do all of these things in your practice. You have a highly endoscopic practice, of course, but any other words of advice?
I would echo the comments of the other panelists and state two things. First, stapedectomy should be the last thing you would consider doing with the endoscope, unless you plan to practice your flap elevation and exploratory tympanotomy with the endoscope, then that's fine. But I think I would complete the stapedectomy otherwise with the microscope. It's an elective procedure. It's beautifully done with the microscope. There's no reason to change that. Second thing is, I found that the first cases that were really ideal were if you're right-handed, it would be a left ear in an older child or an adult with a larger ear canal, and a patient with a retraction pocket that normally would have tackled through a post-auricular approach. Those I found to be the ideal first cases. And that's when I really began to appreciate the true advantages of a transcanal endoscopic assisted approach, were those retraction pockets that I could just never see the bottom of unless I made a big incision that I could easily see even with a 0 degree with a Hopkins rod system.
Yeah, that definitely good advice and good thoughts there. Those are the cases that I think change your practice patterns and really get you excited about doing things endoscopically. I would just ask the reverse question, and I think Dr. Lee has already answered this. These are pictures of a case of otosclerosis and a stapedectomy here. And I would agree that is a challenging case to begin with from a microsurgical and technical standpoint, and certainly would not be the first case to try endoscopically. But going back to Dr. Cushing, any particular cases that you have concerns with doing endoscopically, whether at the beginning of your endoscopic career or even now, being a very experienced endoscopic surgeon?
I think, we don't look after stapes, so, but I would echo that. I think sometimes the biggest risk as you get further on in your learning curve is not knowing when to stop with the endoscope. And so, I had this period in my career where my skills were increasing and, I was pushing further and further back into the mastoid with an endoscopic approach. And I'd end up with these massive adicotomy defects that would then lead to recurrence. And so just because you can do it doesn't mean you should do it. So I think that is one of the things that I've seen. And I think Adrian experienced the same thing where we sort of, you push it because you can, and then you realize the outcome and then you bring it back a little bit. So sort of knowing when to stop, I think, is an important feature. But otherwise, I think that, there's a role for endoscopes in most of these cases, or at least the ones that I do as a pediatric surgeon.
Yeah, no, that's a very good point. It's so interesting to listen to your experience, Dr. Cushing, because I've had so many similar experiences in my practice where that is certainly part of the learning curve, and understanding when to stop with that cholesteatoma endoscopically is certainly a very good point. For Dr. Kakahata, any comments on cases that you think are particularly risky with the endoscope? Any of these that you wouldn't venture to do?
Okay, so I totally agree with Dan and Alicia. For otosclerosis, stapedotomy should be the last case for your practice. So, and one more thing, hypermobile stapes dissection for cholesteatoma is also very has potential risk, because in a one-handed surgery of teeth, you cannot use left hand to hold the stapes. So in that case, we use non-slip surface treatment technology forceps to remove matrix dissection in the case of hypermobile stapes.
Ah, yes, a very good tip. I loved that video, especially the video of your special forceps holding I think a 5-liter bottle with these forceps that can remove cholesteatoma up a mobile stapes. Great. So our third question, this is perhaps directed more toward Dr. Lee first, and then we can get the other thoughts. But what are your thoughts, Dr. Lee, on could the exoscope actually replace the microscope in the future? And if you had to think about safety for using the exoscope for anybody out there who is willing to engage and try these new exoscopes, what would your advice be?
Thank you, Alicia, for the question. The exoscopes are ready for prime time use today, and I think several of them are more than adequate to be able to replace a traditional microscope in all conditions. I would certainly be excited about having one full time and giving up my Leica scope to somebody else. So I think the technology has arrived. I would certainly strongly recommend that if you are interested in incorporating a system into your practice, that you should trial several different systems, because they have pros and cons in terms of footprint, the size of the end effector, which is the thing that you move around to bring light and capture your live video feed, and also always have your operating microscope in the corner of the room, certainly at the beginning, so that you have your backup ready to go if you're not happy with how your exoscope is performing. But the exoscope does free up both hands, so it is like a traditional microscope in that way. There was a question regarding whether you can see around the corners like with an endoscope, and the answer is no. You can see as well with an exoscope as you can with a traditional microscope. And so it's really meant to be able to overcome the ergonomic disadvantage of the stack height and the binocular system seen with our old school microscope.
Terrific. And for Dr. Kakahata, has has the exoscope already replaced the microscope for you in some of your cases?
So I agree with Dan again. So exoscope is very nice device, but still it's not good as a microscope because when you want to see the deep in the middle ear, you cannot get in high magnification, you lose, you cannot see as good as microscope. So in that point, so 4K, it's not the 4K at all. When you magnify the exoscope, it's not equal to a 4K. So I mean, still we wait 8K or 16K exoscope.
I would echo Seiji's responses and also state that they need to develop, the industry needs to develop more ground glass optics, right? We need optical zoom. And if you're relying on both optical and digital zoom, well, as you suggested, the image degrades fairly quickly at the highest levels of magnification. And so this is all just a hardware issue. And so there's no question this will come, as well as reducing the bulk of the system and making it more user-friendly.
Thank you, Dan.
Yes, a peek into the future. There's something certainly incredible about having this multiple foot large screen in front of you with 3 dimensions. There's something fun about that, I think, as a surgeon. But yes, it'll be interesting to see if there's continued improvement of the visual, the picture quality as we go along. And Dr. Kuching, have you had experience with exoscopes at your hospital?
I have, and I'll also sort of bring the psychology and, personal side to it, is that, like, we've had a system on trial here, and part of it is it's hard to adopt new technology, right? And so, you've got a huge list that's overstuffed with patients who've been waiting, and you're like, oh, should I make room for this new technology? And sometimes we have, and Adrian's done a much more beautiful job than I have. When I walk into the operating room in the morning, the nurses are like, are you going to use the exoscope? And they're like hoping I'm going to say no, right? Because it's new and it's harder to set up and it's unfamiliar. So I just, I put that out there as sort of the realistic challenges, and also a credence to my colleagues who, do make room for it. Like you have, Dan, just because it is hard in the institution to adopt new technology. But, I really, can't wait to see what our operating rooms look like in 10 years.
Terrific. Well, thank you for those answers. We have just about 3 minutes left before I turn it back over to Dr. Zafirio. So I think we'll have time for maybe one quick case and get all of your opinions. This is a 43-year-old male, and we'll just go through your opinions on this case. 43-year-old male who presented with what appeared to be a cholesteatoma in the office, appeared to be an attic cholesteatoma. You can see his audiogram on the left here. Ironically, the right ear was his better hearing ear, but had an air-bone gap there. And then you can see some of the imaging here. We're looking at CT scans and MRIs. Unfortunately, these are not the fusion CT MRIs that Dr. Kakahara showed so beautifully. So you'll have to put it together in your mind. But we are looking at what appears to be a mass surrounding the heads of the ossicles here on an axial. You can also see that in the coronal with this classic erosion of the scutal bone, which is typically consistent with the cholesteatoma. And also on the coronal, you can appreciate that there's a defect in the skull base here at the epitympanum level. And obtaining an MRI demonstrated that that area of tissue that you saw in the CT scan was diffusion restricted, and so likely to be a cholesteatoma rather than a meningoencephalocele, which would be brain tissue herniating through that. So just, I think in the interest of time, maybe I'll play the video and ask for some opinions on how would you approach this, and just to switch things up, starting with Dr. Kakahara.
So I'm going to do TIS because in this case, tegmen is very low. So that's a good indication to use endoscope instead of microscope. So still, it has a dehiscence we can manage by teeth, I think.
Excellent. And Dr. Cushing, any thoughts on this case and how you might approach it? I'll just point out for the audience here, what you're seeing here is a right ear. You can look into the epitympanum. We're seeing actually the dura here and cholesteatoma being removed.
Yeah, I think the video, tells us just how beautiful you're seeing. So even though you have that defect there, you're able to visualize it in a beautiful way. And it seems that it's very reasonable to do this case endoscopically. I think the important thing too is that you can always change your mind. And I think even cases that from the go, you're going to open that mastoid, I still now start those endoscopically because that part, it's always easier to do the middle ear dissection with an endoscope, when that is a technique you're used to using. So all the more reason to start in this case. And you've done a beautiful job of it, I have to say.
Thank you for that, Sharon. And for Dr. Lee, any tips or pearls on a case like this? What instruments you might use? I know I use a lot of the instruments that you have personally designed in the operating room, but any tips or pearls for this type of case?
Well, really fascinating case, beautiful dissection. I guess one doesn't really know what the state of the dura will be when you peel off that matrix. And I'm sure you prepared the family that you may need to turn a temporal cranial flap to be able to address the defect if it came to that. Because of that middle fossa approach and the middle fossa involvement, I would certainly be interested in a second look procedure fairly early after this procedure, or at least to follow the patient with imaging as well.
Yes, all good points. And that certainly echoes even what Dr. Cushing had said earlier about not promising too much with these endoscopic approaches and being prepared to convert when necessary. And this patient did have a second look surgery, as you suggested. So with that, I think I'll conclude and just really thank our incredibly esteemed panelists. I'm so honored to have been part of this. So thank you all for your incredible presentations, and I'll turn it back over to Dr. Zaffirio. Thank you so much.
Thanks so much, Dr. Quinnell, and to all of our speakers and panelists, moderators for such a great global grand rounds. We have about 2 minutes left. So thank you to Dr. Quinnell and Terabici for co-moderating, and Dr. Cushing, Dr. Lee, and Dr. Kakahara for such inspiring presentations. Truly was a pleasure to be here with all of you and all of our participants from over 100 countries throughout the world. So, and this will be available by online as well. You will all receive an email which has a recording of this presentation, as well as a link to a certificate for this Global Grand Rounds as well. So just a couple of quick reminders. So we have an upcoming 2023 Global Grand Rounds series. We will have 5 Global Grand Rounds in 2023, the first of which will be in February, same time, also on a Saturday at 9 a.m. Eastern US time, which is at various times throughout the world. The first will be on endoscopic sinus surgery, sort of the latest in technology and advances and techniques. And so we very much look forward. If you enjoyed this presentation on advances and techniques in endoscopic ear surgery, I'm sure you will also enjoy this Global Grand Rounds on endoscopic sinus surgery as well. So we look forward to that Global Grand Rounds in February of 2023. So a brief mention of our in-person annual meeting, which will be end of September, early October in Nashville, Tennessee, which is the Music City. We would love to see many of you in person at that meeting. So please do register and plan to attend the meeting. And then finally, we do have special rates for international membership for the American Academy of Otolaryngology Head and Neck Surgery. Certainly, if you are coming to the meeting, it makes sense to join as a member of the Academy because you get a significant discount on the meeting registration. But we also have special rates for international members, depending on which country you're from. We have special rates. So all of this information is online and will also be emailed to you. So with that, thanks again to all of our moderators and speakers today for such a wonderful and exciting presentations and discussion. And from the American Academy of Otolaryngology Head and Neck Surgery, we say good morning and good night from wherever you are in the world today. Thank you.